Hi, my name is Carolyn Hill. I'm a CNS student working on the pediatric step-down unit. This is AH, an 18-year-old male with a history of a scooter accident with a resulting traumatic brain injury in 2021 who presents with a small wound to his left leg concerning foreign infection. AH noticed a small pimple-like spot on his left lower leg about 2 weeks ago. It has continued to grow slowly but opened up 2 days ago into an open wound. The wound is oval-shaped and measures approximately 2.5 centimeters by 1.2 centimeters. It is well approximated with an open wound bed that is pink with some yellow eschar spots. The surrounding skin is dry and intact. It is not painful or itchy. Nothing has seemed to make the wound worse, but the patient did put Neosporin and a Band-Aid on it starting 2 days ago when it first opened up. That did not seem to help it, per the patient. The wound is not changed based on the timing of the day. Though it is not painful, the wound has caused the patient some anxiety, which prompted him to come to the ER last night. In the ER, the patient was calm and alert at his neurologic baseline. The patient was afebrile and other vitals were within normal limits. Blood cultures, a CBC with differential, CMP, CRP, ESR were drawn and the wound bed was cultured. A PIV was placed and the patient was admitted to the step-down pediatric unit for close monitoring and IV antibiotics. The patient had a scooter accident which resulted in a traumatic brain injury in 2021. At that time, he had a ventriculoperitoneal shunt placed, and he was discharged 2 months later, able to walk, talk, breathe, and feed himself on his own. He has no other past medical problems. His only surgery was the VP shunt placement, which was done in August of 2021 without complications. He has no known allergies. His daily medications include Keppra, Prevacid, a multivitamin, and a probiotic. The patient's parents are both alive and healthy. There is diabetes in the paternal grandfather and pancreatic cancer in the maternal grandfather. They are both alive. His immunizations are up to date. He is a senior in high school and goes to school 5 days a week. He lives with 2 younger brothers and his mom and stepdad. There's no sick contacts at home and no recent travel or tick exposure. On the heads exam, there's no concerns for abuse at home. He swims recreationally. He reports no drug use, no smoking. He was sexually active last year before the accident, but not currently. On my review of systems this morning, in general, the patient denies any fatigue, any weight gain or loss. He denies any difficulty sleeping, denies fever, chills, or night sweats. Neurologic, he denies changes in consciousness. He does endorse 1 headache he had yesterday and 1 the week before. He denies seizure activity, denies weakness or numbness. HENT, the patient denies vision changes, hearing loss, dysphagia, nasal discharge, congestion, and denies sores or ulcers in the mouth. Respiratory, the patient denies cough, denies wheezing, denies dyspnea. Cardiac, the patient denies chest pain, palpitations, or any peripheral edema. GIGU, the patient denies any loss of appetite, denies nausea, vomiting, diarrhea, constipation, blood in his stool, dysuria, denies urinary retention, and denies decreased urine output. The skin is positive, of course, for the wound to the left lower leg. He denies any urticaria, rashes, or pruritus. On physical exam, his vitals are blood pressure 108/66, heart rate 79, respirations 20, temperature 98.9, and oxygen saturation is 97% on room air. The patient is alert and oriented ×4, and he denies pain at this time. Neurologic, the VP shunt is palpable without any tubing exposed on his scalp. The pupils are 3 millimeters and are equal, round, and reactive to light and accommodation. Grip strength is strong on both sides and equal. Suck, swallow, gag reflexes are intact, and GCS score is 15. Respiratory, there's no work of breathing. His breath sounds are clear bilaterally in all lobes. Cardiovascular, he has a regular rate and rhythm with S1 and S2 heart sounds, no murmurs, his extremities are warm, he has 2+ peripheral pulses, and his cap refill is less than 3 seconds. GIGU, his abdomen is soft and non-distended, his bowel sounds are active in all quadrants, his last BM was yesterday. Skin, he has no rashes or urticaria. He does have the wound as described previously in the HPI, and he has a PIV in place to the right forearm. Overall, my impression of this patient is that this is an 18-year-old male with a history of a traumatic brain injury with VP shunt placement in August of 2021 who presents with worsening skin wound consistent with a superficial infection. The patient is in stable condition currently, but is at high risk of decompensating due to the potential for an overwhelming bloodstream infection that could lead to shunt infection or meningitis. Due to his lack of systemic findings, my most likely diagnosis is cellulitis. He did have a few headaches over the past week, so we should consider other can't-miss diagnoses such as meningitis and VP shunt blockage. My plan for this patient, neurologic-wise, we can order Tylenol as needed for pain. I would recommend getting a neurosurgery consult to discuss potentially tapping the VP shunt to evaluate for infection or blockage, and we should perform neuro checks every 4 hours. Cardiovascular, I would like to place him on a cardiac monitor to closely monitor his heart rate and respirations for signs of systemic infection. Respiratory, we're going to monitor his pulse oximetry continuously, and he can stay on room air for stats greater than 90%. GIGU, he can be on a regular diet. We'll monitor closely for vomiting and monitor strict intake and output every 4 hours. Skin, I'm going to mark the area around the wound to monitor for any changes. We'll keep it covered with gauze and Tegaderm and change that twice daily. I would like to get a wound care consult for additional dressing recommendations. ID, we're going to continue with the antibiotics started, which was ceftriaxone that was started in the ER. We should also consider adding vancomycin for MRSA coverage. Labs and imaging, we're going to follow neurosurgery recommendations for any head imaging, follow up on blood and wound cultures, get daily labs to monitor white blood cells, CRP and ESR as signs of infection and inflammation. Health maintenance, I'll call and update his primary care doctor. We should also consult Child Life for developmentally appropriate activities while he's here. Goals for discharge for this patient will be verification of proper shunt function, appropriate antibiotic coverage for the identified organism, no signs of systemic infection, improving wound appearance, improving white blood cells, CRP and ESR results, and a follow-up appointment should be made for 2 to 3 days out of discharge.